Hello, and welcome to Module 5, Wound Etiologies, Pressure Injuries. Our objectives for this module are to discuss the pathophysiology of pressure injuries, define the components of a complete patient assessment, detail the treatment protocol for pressure injuries, and detail pressure injury prevention strategies. Let's first discuss pressure injury pathophysiology. The development of a pressure-induced injury is a complex process that requires the application of external forces to the skin. Pressure injuries, or PIs, form due to a combination of pressure, shearing forces, friction, and moisture. Pressure applied to the skin in excess of the arterial pressure, which is typically 32 millimeters of mercury, prevents the delivery of oxygen and nutrients to the tissues, resulting in tissue hypoxia, accumulation of metabolic waste products, and free radical generation. The tissues most susceptible to pressure-induced injury are muscle, subcutaneous fat, and dermis. Pressures are greatest over bony prominences where weight-bearing points encounter external surfaces, such as lying on a hospital bed. Approximately pressures in this region can be 150 millimeters of mercury. Sitting on the ischial tuberosity can translate into pressures over 300 millimeters of mercury. Patients placed on inclined surfaces are at a greater risk for shearing forces. What are some additional risk factors? The most important risk factors for developing pressure-induced skin and soft tissue injuries are reduced sensory perception or the inability to respond meaningfully to pressure-related discomfort, immobility or inability to change and control body positions, lack of physical activity or the inability to get out of bed, malnutrition and/or impairment of adequate food intake, exposure to moisture from incontinence or other causes, and exposure of skin to friction and shear forces. Additional risk factors include cerebrovascular and cardiovascular diseases, recent lower extremity fractures, surgeries, or injuries, reduced skin perfusion, incontinence, and diabetes. Let's discuss staging and grading of pressure injuries. Grade 1 pressure injury staging includes non-blanchable erythema of the intact skin, discoloration of the skin, warmth, edema, induration, or hardness may also be used as indicators, particularly in individuals with darker skin tones. A grade 2 pressure injury consists of a partial thickness skin loss involving the epidermis, dermis, or both. The ulcer is superficial and presents clinically as an abrasion or a blister. Grade 3 pressure injuries are full thickness skin losses involving damage or necrosis of the subcutaneous tissue that may extend down to, but do not go through, the underlying fascia. And finally, grade 4 pressure injuries are extensive destruction, tissue necrosis, or damage to muscle, bone, or supporting structures with or without full thickness skin loss. The Braden scale is an important tool that helps to identify people at risk for pressure injury development. Braden scale helps to guide implementation of prevention measures. Braden scale is a reliable documentation tool. The lower the score, the higher the risk to develop pressure injuries. A score of 9 or below means the patient is at very high risk of developing a pressure injury. High-risk patients will score from 10 to 12. Patients with moderate risk will have scores from 13 to 14, and patient at mild risk will score from 15 to 18. And you'll see the Braden score here on the right side of the slide. The Braden score will also be in your clinical protocol for your reference. Let's discuss treatment protocol for pressure injuries. Diagnostic testing should include an ankle brachial index or toe brachial index if the pressure injury is located on the lower extremity. Obtaining the Braden score, as mentioned, is important to stratify the risk of the patient. Fluorescence imaging should be obtained. Oxygen assessment imaging should also be obtained if available. Cultures if clinical signs and symptoms of infection are present. Mini nutritional scale should be obtained on intake. And x-rays should be taken if there is concern for osteomyelitis. General measures to treating pressure injuries include alleviating pressure directly over the wound, gently cleansing the wound and patting the area dry, debriding the wound as needed, inspecting the peri-wound tissue and use of tissue protectants, moisture barriers, or emollients as needed, addressing any nutritional deficits, addressing, controlling, and eliminating excess moisture in and around the wound site, treating bacterial colonization based on the moleculate images and/or clinical signs and symptoms of infection, choosing the appropriate dressing per the protocol product picker, and protecting the dressing from contamination from both urinary and fecal incontinence. If the wound surface area has not reduced by 40% or more in the first 4 weeks of care, advanced therapy would be indicated. Consider prescribing topical oxygen therapy using the NATROX oxygen device. The patient would continue to return weekly for evaluation. Patient is reassessed weekly for changes in past medical history, medications, physical exam, or nutritional status. Evaluation of the wound trajectory should be performed, and treatment modification should be based on this information. Wounds not moving into a healing trajectory after 3 months of appropriate treatment should be biopsied. Here is an overview of the pressure injury algorithm. When the patient presents with a pressure injury, a complete wound and patient assessment should be obtained, including diagnostic imaging as discussed. All underlying conditions should be optimized. Patients should be evaluated for signs of infection. If signs of infection are present, the clinician needs to determine if it's a localized infection, and the appropriate antimicrobials should be used. Unless the patient is compromised, no systemic antibiotics are typically needed. Wound dressings should be determined based on the product picker and the amount and quality of wound exudate. If there is spreading infection, systemic antibiotics are indicated and should be based off of culture results. Additionally, secondary dressings should be chosen from the protocol product picker based on wound exudate amount and quality. If the wound has necrotic tissue present, debridement would be indicated, either autolytic debridement or sharp debridement as indicated clinically. Patient progress should be reviewed every 4 weeks. If the wound becomes static or fails to reduce by 40% or greater, consider beginning NATROX topical oxygen therapy and monitor the patient weekly. Let's discuss prevention of pressure injuries. Immobility is the most significant factor for pressure injury development. Patients have a greater intensity of pressure over bony prominences when sitting in a chair compared to laying in a supine position. Managing incontinence, fecal is more problematic than urine for the skin. Cleanse skin gently after each incontinence episode with water or a pH balance cleanser. Be careful to avoid excessive friction and scrubbing, which can further traumatize the skin. Use moisture barrier protectants on skin, such as creams, ointments, film-forming skin protectants, as needed to protect and maintain intact skin or treat non-intact skin. Select absorbent underpads and briefs to wick incontinent moisture away from the skin versus trapping moisture against the skin, which will cause maceration. Separate skin folds by using a skin sealant and change dressings frequently. Minimize and eliminate pressure from medical devices, including oxygen masks, tubing, catheters, casts, NG tubes, G tubes, and restraints. Limit the number of linen layers between the treatment support surface and the patient. Maintain or enhance patient's level of activity. Inadequate nutrition may be reversible. These risk factors are present for pressure ulcers, so provide multivitamins and mineral supplements if intake is poor or nutritional deficits are suspected or indicated by lab values. Use pressure support surfaces as indicated. Free float heels by elevating the calves on pillows and keeping heels free of all surfaces. And at a minimum, patients should be turned every 2 hours. So in summary, in order to prevent and treat pressure injuries, it is important to identify the at-risk patient. Risk of pressure injury can be assessed by using the Braden scale. The singular most important treatment modality for pressure injuries is effective offloading and pressure distribution. Additionally, successful treatment plans must focus on optimizing the local wound environment and preventing infection. Here are some additional references. And this concludes Module 5. To complete the test, please click the red test icon at the bottom of your screen with the clipboard and pencil on it to receive your certificate of completion for this module. Thank you.